All right. Well, thanks everybody for joining us. We're going to go ahead and get started. I'm Emily. We're going to start with a little brief introduction of everybody who will be presenting today, and then we're going to jump right in. Kind of the birth of this webinar is we remember how stressful it is to start on away rotations. This is a incredibly courageous thing that you're all doing, trying to get into a very, very competitive and rewarding specialty. And we wanted to put together a webinar that can help for the beginning part. And this year is very long, so our topics today are going to focus more on the stuff that you're going to need to focus on for the very beginning. So without further ado, here we go. So Dan Lee is going to be joining us from Ohio State. He is currently a chief resident there. Dan and I met a long time ago when he was in your shoes as a student. So now from the other side, Dan remembers what it's like and has got a lot of tips on how to shine on rotations. Jacob Triplett is, wow, we've got a lot of Ohio here. So Jacob graduated from residency from the Ohio Health residency in Columbus, Ohio, did a fellowship in shoulder elbow, and you guys probably know and love him as the co-founder of Pocket Pimped, as well as this guy. So David will also be talking with us. They went to the same residency. I don't know if everybody knew that, but that's where the Pocket Pimp book was born. Paul is joining us as a little bit more of the rookie. He is the closest to the process that you guys are all undergoing, and he is currently a resident at the Medical University of South Carolina. And then there's me. So I'm Emily again. I did residency also in Ohio at Kettering Health Network. I did a hand fellowship, but probably the most pertinent to this is white coat coaching. All right, let's jump into it.
Everybody can see that just fine. Awesome. All right, so again, thanks, Emily. I'm David Johnson, and Jake and I are the co-founders of Pocket Pimped. We'll go ahead and get this started. So our aim today is just to show you how to succeed on your rotations and just go over some of the must-need facts that you're going to need to know for your rotations. Maybe. There we go. So overview, we'll go over some pertinent resources, how to prepare for cases, both cases that you know are going to happen and then add-on cases that'll happen the day of. Go over some of the basics of things you need to know, hit some highlights for anatomy, and then go over some basic classifications. So here are the resources. Obviously, there are a ton of resources out there for orthopedics, from journals to textbooks to apps, you name it, and somebody has created it. We tried to pare it down and kind of go through what we used and what we saw students use going through when we were in training. So obviously, Pocket Pimped is the product Jake and I worked on together. It's excellent for knowing what's important, and you'll see as you go through your rotations that there's all the same questions are always asked, and they're not necessarily the most clinically relevant, but they're the ones that are commonly pimped, and that's what you're kind of judged on as a student. So our book is a small pocket-sized book that's great to carry around to know the important things. There's also an app that goes along with it. Handbook of Fractures is great for basically fracture work. It goes into a lot more detail in regards to fracture fixation, kind of working up different fractures, the things you need to know there. And then the Netter's anatomy book is probably the best resource for concise anatomy, which is one of the things you're going to be asked about most commonly. And then the other resources we like to use were ortho bullets. It can be sometimes too in depth for the medical student. but it's an awesome resource. Goes through pretty much everything you need to know from a medical student all the way up through passing your boards. Miller's is also a great resource, but again, can be somewhat too in depth for a student trying to learn orthopedics. It's certainly a different language, and it's something you're not really taught in medical school, which is why starting out can be so difficult. As a student, you just need to start getting your understanding and build the basics, and that's how you become successful. And then looking at certain journal articles, whether it's AOS or another journal, there's certain articles that you'll find keep getting cited, and it's important to read those as a student. So how to prepare for cases. The most important thing you can do the day before or the night before is to know what you're going to be getting involved in the next day. So always ask your resident or other students, or whomever you have, to tell you what cases you're going to have the following day. That way you can prepare the night before. So things you'll need to go over. The anatomy is the one thing that never changes. So it's something that you're asked about most commonly. It's basic. It's something that everybody learns in medical school. And it's a good starting place for people to ask questions about. So you'll certainly get asked those. You can also, rest assured you'll get asked about the classification system, if there is one for the case or the fracture that you're fixing. Now, it's important to review the Ortho Blitz topic the night before, just so you have a good overview of kind of anatomy, the workup of the condition, the treatment options for it, and then ultimately what you end up doing. I'm sure will be listed on there as well. And then use the pocket pen book to know kind of the questions you're going to get asked and the important things, so that you can make sure that you nail the questions that you're going to get asked as a student. That way you can shine in your rotation. And then lastly, look up a video just so you can kind of have an idea of what you're looking at, what the attending or the resident is looking for, and just kind of how the case goes along. It's much different when you know what cases you're going to be involved in compared to showing up and you have add-on cases from trauma call, or you're on call overnight and you do an emergent case. These are a lot more difficult to prepare for. So my advice here is to just remember that common things are common. So hip fractures, ankles, wrists, those are things that you'll commonly get when you're on call, commonly get thrown into. But it is very stressful going into a case that you were not prepared for and know you're going to get asked questions about it. It's certainly stressful. So trying to hit the high yield things first. So once you've already prepared for your scheduled cases every night, I would start looking at certain cases that are common, like the ones mentioned there. You can always excuse yourself to go to the restroom, or while you're waiting for the patient to come back to the room, go over anatomy, go over pocket pen questions, the things that you're going to get asked about. Being prepared is probably the single most important thing throughout the entire rotation. It's something that you'll get judged on because it's a level playing field. So your preparation for a certain case is an indicator of how important you think it is and how seriously you're taking everything. So there's no excuses to not be prepared for scheduled cases. So stay up late, get up early, whatever you have to do, find out which one works better for you. I'm more of a morning person, so I'd rather get up at 4:30 and study for a case and be prepared than stay up till midnight the night before. But whatever you have to do, you have to do it to make sure you're prepared. And it was always, when I was going through, when you got tired, when you didn't want to prepare anymore, just remember the person that you're going to be judged against for that particular residency spot is probably upsetting. That'll give you the drive to keep going. So just a couple examples of how to prepare for cases. So this would be for an ACL. So the plan the night or the morning of, read through the Ortho Blitz page, know the different types of ACL reconstructions, whether you're going to use autograft, allograft, whatever the case may be. You can watch videos of different techniques on ViewMedi or YouTube. And then lastly, go through pocket pen to know kind of which questions you're going to get asked. And ironically, the ACL reconstruction was the first topic Jake and I went through and did for pocket pen, and somebody else in our residency who did not know we were putting the resource together went through and asked another student every question almost in order from we had, and that's kind of what made the idea of pocket pen go forward. We have these videos out. You can find them on YouTube. They kind of go through basically what you're going to get asked during the case, and then the execution. So, what are you going to get asked during the case? What are the bundles of the ACL? What are the exams? What's the Sagan fracture? All these things that are predictably asked, and you certainly will get asked during the case. So add-on cases, a calcaneus fracture is a great example. It's not the most common fracture in the world. you probably weren't expecting to come in the morning and have one. So maximize the high yield things you're going to get asked about before. If you have time, look over ortho bullets, certainly look over anatomy. And again, you'll get asked about classifications. You'll get asked about the x-ray angles, approach, kind of all the things that are pertinent to the case. There, I'll give it back to Jake to continue.
All right. So, Dave did a great job at kind of reviewing, the importance of, I think it's very different, whether you're going to have a case the day before the morning of, and those are really challenging situations because, if the next day you have a case, it's very easy to prepare for the case. But to Dave's point, knowing the morning of, especially when you're on the trauma rotation, what exactly you're going to be asked is really quite challenging. So, basically the one of the crux of our books is, if you're in that situation, what questions am I actually going to be asked? How can I make the most of this kind of last minute situation? So, but obviously it's very hard in 15 or 20 minutes to go through really everything we must know regarding the basics, but we kind of just cherry picked a few things that we thought would be worth sharing. Particularly, I'm not sure where everybody is in their journey right now on the rotation trail, but we wanted to pick some kind of things that you're almost guaranteed to be asked about while on rotation, if you're taking notes or anything like that. So, radiographic lines of the pelvis, this will probably be one of the first things you'll be asked about, especially if you're on any type of trauma rotation, because these lines are very important for pelvic ring injuries, for acetabular fractures. So it's very easy to lend itself to a question, and knowing which line correlates with either the column or the acetabular wall or whatever it may be. But I would say for sure you need to know the radiographic lines of the pelvis. And I'd say, the algorithm to match orthopedics is really not hard, right? It is a good attitude, a willingness to work, and showing proof of preparation. And I think when you get to certain things like this, a splinting or whatever it may be, this is one area where the medical student on the rotation can really make the difference between a rock star medical student and an average medical student. So if you look on the left here, I kind of went through and put together just some very common, whether it's a sling or a coaptation splint or a AO splint. Basically, if you kind of just know that column on the left there, you almost know what type of splint is applicable for any type of injury in that area. But what I was getting at was the medical student who helps the resident life be easier is the one that the resident's really going to remember. So if you go through and you have an ankle fracture, and your job is going to be this guy right here, the one holding the leg, holding the foot, paying attention how to do that, knowing which supplies he used on the last AO splint he put on, and then knowing that if you have another one, can I grab those same supplies? So it's very easy on the rotation to just say, oh, he's going to tell me what to do, or she's going to tell me what to do. But paying attention to the little details, like, okay, he had plaster splint, he had a double 6-inch H wrap, he had 4-inch web reel or whatever it is, and having that stuff available, I think would really make you look potentially like a rock star in the rotation. And what Dave alluded to earlier is we went through and we made a bunch of videos that are either on our Instagram account or on our YouTube page that kind of go through a lot of high yield stuff. And I think this is one in particular that would be really useful for the medical student about to go on the orthopedic rotation, because let's see if it plays here, because it basically shows how to put on a splint. I'm not going to play the whole thing, but my point is if the resident came in and you had this table here looking like that before they got in the room, I mean, this is a wow factor for sure for the residents. So I think this is a very easy way to make kind of brownie points on the rotation. Infection, unfortunately, even though we don't like them, is a very commonly asked question because we get quite a bit of consults in orthopedics regarding infection. And the emergency department tends to think almost everything is necrotizing fasciitis. So you're going to be consulted for this routinely. And I don't think the specific values are important to know here, but knowing what the scoring system is, knowing that if you literally Google search neck fash scoring system, there's an online calculator that pops up right away, and it will literally generate a point system and tell you what the likelihood that this is neck fash is. But the thing that would be important to know is to know which labs are actually important. So a CRP, a white count, a hemoglobin, sodium, creatinine, and glucose. I think those would be the things that would be expected of the medical student to know. So generally speaking, if you get a CBC, a CMP, and a CRP, those three labs will be able to calculate the scoring system for every neck bash rule out. Similarly, sticking to the infection theme, you'll get consulted quite a bit for hand infections. This is a very easy PIMP question for the resident on call to ask you. Basically, how do we rule out flexor tenosynovitis? And the four signs are the Knavel signs. So knowing these four exam findings are basically how we rule in or rule out flexor teno. So this is going to be a very common one that I'm sure you're going to see on your audition rotation. Similarly, septic arthritis, prosthetic joint infections are a very common one, but this is probably the more important one to know as a medical student. Knowing that a joint aspiration, a white count more than 50,000 is diagnostic. Either polymicrobial infections or Staph aureus are very common bacterial findings for this. So I think the 50,000 is probably the most important thing to know in this question. And then similarly, probably one thing you will for sure encounter is the rule out compartment syndrome. And the things to remember here are really the P's. The most important thing on examination to rule out compartment syndrome is pain out of proportion. That's the most important thing. And this is really a diagnostic diagnosis, clinical diagnosis rather. And then, we talk a lot about compartment pressure monitoring and all that stuff. That's really to either support your suspicion or confirm your lack thereof. But this is primarily a clinical diagnosis. But the most important thing to remember is pain out of proportion is the most important finding on examination. These other findings, by the time you get to paresthesias, paralysis, pulselessness, that's pretty late findings for compartment syndrome. So just keep that in mind. Obviously, we can't review everything anatomy, upper extremity and lower extremity in 15 minutes. But, again, the one thing that is probably one of the highest yield content you can know as a medical student rotating in orthopedics is your anatomy. And that's particularly important when you'll be asked about the compartments in the upper extremity and lower extremity. Often you'll be asked what are the contents within these compartments. Innervations of muscles are expected, but the ones that are more commonly asked are the unique ones that might have a dual innervation, such as the brachialis, or if there's some weird nerve anastomosis. I've been asked those as a medical student as well. And then, a lot of times you're going to encounter fractures that have certain deformities, and anatomy is very important for these questions because the anatomical structure that attaches to the bone will lead to the deformity that you see there. Again, you're going to be on a sports rotation most likely during your rotation. Another video on YouTube we went through, and we did a really good video that basically goes through a diagnostic shoulder arthroscopy. This is very, very easy questions when you're a medical student to go through and say, what's this, what's that? So make sure you visit our YouTube page and check these out, because having a basic understanding is going to be super important for you. So I won't play all of that. Similarly, nothing new here. Lower extremity, same thing. Just, I hate to say it, really just know your anatomy. But again, know the compartments, the content within the compartments, and again, what's going to lead to those deformity forces. So these are just, I actually went through and wrote down the classifications that I consider must-know classifications. There are several other classifications that are in our book as well, just kind of more the outlier classifications. But I would say these, if you want to take a screenshot of this or whatever, these are the classifications that for sure are expected to be known by the medical student. So all of these are in the book, and it basically goes through all the classifications. So you can literally say, okay, you know, this is a garden 1, this is a garden 2, or whatever. All that's outlined in the book for quick, easy reference for you. So for getting pimped, again, the biggest thing is be prepared. It is somewhat of a game, and the goal is to make it as far as possible. You know, answer the question that you were asked. A lot of times it's very easy for the attending or the resident to know whether you know the question or not. And you'll see a lot of medical students try to give a different answer to a different question because they're trying to hide the fact that they don't know the answer to the question that was asked. So it's okay to not know things. If you don't know it, just say, I don't know, and I'll look it up. But make sure you actually look it up, because I could tell you nothing's more frustrating than when you ask a medical student the second day the same question and they said they were going to look it up and they didn't. So it almost makes you look really bad in that situation. So if you're going to say you're going to look it up, make sure you do. Even though we talk about, you know, knowledge and knowing what questions are going to be asked, by far the most important factor is attitude. So if you know all the content in the book on ortho bullets in Miller's, but you have a bad attitude, you're not going to match. Conversely, if you have a good attitude, but you don't know the content, you're likely not going to match. So it's really a combination of the two. So have a good attitude. Make sure you're well prepared. You know the knowledge. Remember, this is your last chance to match into a very competitive specialty, and you're competing with a lot of people who are very dedicated and committed to this. So again, Dave and I are very biased, but basically we went through and we did the work for you. The book is literally designed to give you all the questions you're likely going to be asked and the answer to those questions. It's not in a paragraph format. It's literally a question and answer style. If you want something more in depth and a long explanation, that's what Miller's and Ortho Bullets is for. Be well organized, work hard. If you're asked to stay, the answer is always yes. Don't go home, it makes you look lazy. And remember, the residents and surgeons, they're to be respected. I see a lot of flaws in medical students in this area here. They want to try to relate to the attending, even if it's like a very chill, cool attending. They have a tendency to almost treat the resident or the attending surgeon like their friend. Remember, respect them as residents, respect the surgeons. You're there to impress them with your attitude, your work ethic, and your knowledge. You know, obviously it's a very political, socially driven world these days. Keep your opinions to yourself, whether it's political, social. Don't even step into that arena. It can only end badly. But most importantly, have fun. And I think if you do all these things, you work hard, you have a good attitude, and you're prepared, your chance of matching into orthopedics is going to be very successful. So Dave and I obviously wish everybody the best of luck. Again, we have a lot of free content on Instagram. We have a lot of free content on our YouTube page. If you feel inclined to get the book, we think it will be certainly helpful for you in your journey. But either way, whether you get it or not, we wish you everybody the best of luck. And if you need anything, we're always available. Pocketpimp at gmail.com is our email. So we did put together a code if anybody's interested. So feel free to use that if you want to. But otherwise, I'll turn it back over to Emily.
So Dan is going to be presenting next, but as he is pulling that up, I just wanted to say that we are taking the questions in the chat. So if you chat, it comes straight to me. And then we will be holding most of the questions until the end, and we'll try to answer them in a panel style. So you'll get kind of an array of opinions. All right, go ahead.
All right. Thank you, Emily. Thank you for hosting this. And, you know, my inspiration for this and kind of joining in was kind of born out of frustration. Because I think, you know, when you're a med school student, there's a lot of anxiety going around in the process, and there's a lot of attendings or administrators that don't necessarily maybe are too far removed from the process, or they're worried about just, people matching IM or surgery. And it's a very isolating process. And sometimes you just need people to spell out, what exactly you should be doing on a away rotation. And so for me, the purpose of this talk is kind of give you a general framework and outline of approaching the common scenarios you'll encounter. So in the OR, as well as being on call. So I'm going to go through a few different things. OR etiquette, and I really want to lay out a framework and really spell it out step by step. And some people are able to pick it out quicker, and I personally wasn't. But this at least gives you that framework. And then presenting the residents on call, and then common call scenarios. So we'll start with the OR, right? And again, every institution is a bit different. I rotated I went to Northwestern, so there, Michigan, as well as Columbia, and then Ohio State. But kind of use that first week to really get a feel of what exactly is going on. Don't be too overeager, because that can ultimately hurt you more so than it helps. And you want to remember that you're learning to be an assistant to the resident, and that is your number one priority. So when you're in the OR, I want you to think, going off Jacob's point, you don't want to be too buddy-buddy. And the reason is the resident is really stressed, and so is often the attending, right? The resident is trying to impress the attending, and attending is trying to get through the case. And so relationships with the resident and attendings are built more so, I think, in the clinic than in the OR. So there's common misconception that when you're in the OR, you're like, oh I need to impress them with my medical knowledge. And it's true, you want to, but you really need to know the basic approach, neurovascular structures, some of the kind of common PIMP questions, but we're not expecting you to know how to do the case, right? And oftentimes, if you kind of interject too much, you sometimes have more to lose than you do by gaining from by being too annoying. And we see this in types of asking questions that you know the answer to. We've all done this process. We've played this game, unfortunately, and we know what it's like. Again, you don't really have to be the best surgeon in the OR, but it does help if you know a bit about suturing. But again, that is not what makes or breaks you. And when we have our roundtable discussion at the very end, right? So we put your face up. It's kind of like a fraternity rush type of situation. It's like, oh, how was this kid? They are never commented on if they were good or bad in the OR. And most times when you are remembered for being in the OR, it's usually not a positive. It's like, oh, they did this. And so my point is, take some less pressure off of yourself in the OR. When you do go in the OR, treat everyone with respect, obviously, that goes without saying, but also introduce yourself to everyone. I see med students just going in, might write their name on the board, and then they don't introduce themselves to the scrub tech or the nurse. Don't be like this character. If you don't know, he's the good doctor. He's an autistic doctor. You are not as brilliant as them. Regardless, don't be like that. And know that too, the ortho OR culture has fundamentally changed from the stereotypes. I know we joke about this a lot, right? And I'm pretty raunchy myself, and I've been burned by this. But if you have a cool resident, you have a cool attending, or you think you're cool with them, you want to build rapport, right? Want to throw in a joke, maybe, that's fine. But just know that just assume every attending and every resident is going to hear that same joke, right? Because word spreads around fast, everybody talks. So if you think that this joke is going to work with one attending or another resident, is it going to work with everyone else? So just think everyone is talking about you. It's like a game of telephone. Obviously, don't talk negatively about anyone else, especially your own institution. Others can gossip, you can't, and unfortunately, you're just not quite one of the boys or the girls yet. And I know it sucks, right? But this is how it's played. So I'm just laying it out to you as straightforward as I can. Remember, the whole rotation, you got a month, right? There's snipers everywhere, and it's all about avoiding landmines. All it takes is one bad impression, one bad joke to kind of sink your entire rotation, because at the end, that's all that you'll be remembered for. So it's not about proving that you're the best medical student and you remember all these facts and right? It's making sure you don't step on the landmine. It's not about hitting the winners. It's just about not making unforced errors from a tennis analogy standpoint. So step by step, create a checklist in your mind mentally before the patient gets in the room, right? Scope out the room in between cases, and once the patient gets in the room, oftentimes you can text the resident when the patient arrives. You don't necessarily have to hover and be the resident shadow the whole time. Pull up imaging on the computer, X-ray, MRI, CT. Some places it might be part of the culture to get a hard copy printout of the fracture and literally tape it onto the wall. If it's a total joint rotation, you should pull up templating and know the templating. And then especially high yield tip, if they have a previous contralateral hip joint, know the sizing of the femoral component, patellar component, write it out. And that is kind of an upper level move. Obviously, write your name, MS4 on the whiteboard before the patient gets in the room. Grab gloves for yourself, and then ask the resident what their glove sizes are, plus or minus getting an extra gown. And then, of course, ask the scrub tech before, just putting their gown onto the Mayo table. Okay, so now the patient comes in, right? They get wheeled in. You got to help transfer them from the OR table to the actual OR bed. You take the bed out, put on SCDs, carry silk tape. That's always useful, and know where the extra pillows and blankets are, because they're oftentimes used for positioning, making a bump, etc. For lower extremity or upper extremity cases, hold the extremity so that there's a plastic drape. It's called a 1000 drape that's used at many institutions, and you can put it on the tourniquet, help the resident do that. You want to help them shave. Sometimes, depending on the attending or the case, you have a pre-scrub with alcohol or chlorhexidine. And then finally, ask the nurse if they would like assistance holding extremity like a heavy leg for prep. Again, this is somewhat of a showmanship, right? Like, we don't actually need you to be in the OR doing this. You're trying to there to be a good assistant. But all these, when you do it, it does show initiative and effort, which is really important. There's little things that I added on the bottom, yellow foam tape to prevent, ulcers from forming on the heel or something, bumps, axe rolls, bone foams, chucks, adjusting the OR lights even pre-op. Makes us know that, okay, you're at least thinking about the case. We get intra-op. Okay, less is more. Usually we prefer, frankly, if you scrub in last, and the reason is if you scrub in first, you're kind of there awkwardly, you're taking up space. We don't want you to drape, because most of the times, you're at a higher propensity to contaminate, and it just creates more anxiety for the resident and the attending because they're very particular. So scrub last, don't touch the Mayo. If you want anything, ask for like a Ray Tech or a lap. And then for sports cases, which you'll often be on, let the scrub tech do their thing. Let them set up the instrumentation for a scope case. There's a lot of wires and tubes, right? You can, especially later on in a rotation, ask for small things such as retractors, but again, be very cautious about that, because that has burned people more than it's helped. At the end of the case, when you're closing, ask how long to cut the sutures. Be diligent about it. We sometimes see students just kind of haphazardly, let me snip it and almost look too cool. We want to see effort. So even if you look like a dweeb, like 2 hands cutting it, it's better than, just laissez-faire cutting a suture, which is frankly the extent of what you're going to be doing in the OR during this period, right? If you're attending, ask for a rongeur, it's okay to ask for a lap or hold it for them. And then if you contaminate something, say it. And that's not just from a patient care's perspective, but those was actually commented from me personally, because I contaminated and I said it, and actually came out at the end of the evals, like we had a kid actually, not hide from the fact that he contaminated something. So be honest with that. After extubation, transfer patient, wheel in the PACU. Sometimes we let the students give handoff. Again, that's institution resident dependent. And again, cycle repeats. Scope out the OR room. Text the resident. You can help clean up the room too, literally wipe down. the bed. But again, clear that with kind of your scrub techs and nurses. Now, OR, again, try to avoid the landmines. And call, though, is where legends are made. This is what's most frequently commented on by the end of the rotation, how helpful a student was during call. And again, the mindset goes back to, you're on with a PGY 1-2, right? They're stressed, right? You don't want to make more work for them. The first thing, even before I go into night call, is floor work. You got to crawl before you ball. Kanye, right? You got to learn to assist the intern, getting the numbers, running the list. This is nothing new. You should be getting the supplies ready, grabbing the dressing and drains. And then I listed out shears, 4x4s, ABDs, yada, yada. And you can grab like a bag and have all these supplies. It's okay to look like a dweeb. At the end of the day, we don't care. We care that you're helpful and that you're putting in effort, no matter how lame you're looking. That shows effort. And from a logistical standpoint during college, I think it's important to know, wherever you go to a new place, try to get a lay of the land where the ED is, and specifically where the supply closet, where you get your supplies are, as well as where the C-arm is. Oftentimes we have a consult comes in, we're like, oh, hey, why don't you run down, or let's look up this patient and you can scope out this patient. I'll meet you in the ED. And we always like it when students show initiative by saying, oh, I can run down to the ED or supply closet and start setting things up. I think those are magic words that every resident wants to hear. It's like, oh, this person is going to help me start setting up what I need to do for a splint or a lac repair, right? Another small bonus tip is also, depending where you are, you can also offer to start writing the note when you're with the patient in the room, or you can have the resident pull up their account and then you can type in the note, get the note templated up, and save the resident some time. Splinting, the big three, right? Web roll, plaster, and ace wrap. So depending on what it is, you're going to use 4 or 6 inch ace wrap, plaster, and then 4 or 6 inch ace wrap, obviously web roll. When you get to a room, put a piece of cloth down to make sure that by the end, when everything's cleaned up, you can just easily dispose of the thing, not make a mess, right? I know the previous Jacob pointed out, there's videos on this, but again, reiterating that you want to be the person getting all these splint supplies set up. Second, again, why logistics, right? Know where the mini C-arm is, and as well as lead. You might not necessarily need to know where it is exactly. Go with the resident, to find it, but definitely help them put it back, right? Remember those routes, and so you can save them time. They're running around to see another consult or do their note, or they're texting their attending or their senior to staff it. But you can start cleaning the whole room and putting these back or bringing them to the next room. The other thing you can do is drawing up lidocaine for any type of block, right? That is the other thing that you can, ask the resident, ask the nurse when you get down there. You can start going to the closet and drawing everything up. When we do ask some students to go down, kind of scope it out, there is a general format of how you can kind of do an informal presentation to a resident. And this is a typical template that you can use as a start, right? This is something you could either say over the phone or text it to the resident if you're not with them. But very briefly, it's, we have an X-year-old male or female with past medical history who presents after whatever mechanism with a closed and open femur, tibia, ankle, etc. fracture. On exam, they're open versus closed and neurovascularly intact distally. Imaging demonstrates in this case, a bimal ankle fracture. And then, I would think that plan for additional imaging versus some type of fixation. We don't expect, the plan, but we do expect a generalized, decent presentation in the sense that we know that you've thought it out. You're not just spewing words at us. I think that shows a level of maturity. So the next step, oftentimes, and this is something that you can screenshot or we'll have the recording, but this gives us an example or a template of, depending on the injury, what imaging comes next. So there's no way that, or it's very often that the ED only orders that one X-ray to consult you. And the next level thinking is, okay, what is the next X-ray to get? So I won't belabor this point, but again, this is a template of what you can do and start thinking about when you take call. AO Surgery Reference, for those of you that haven't used it, it's a great website where they basically have every single body part, and you just click on the body part. It breaks it down by what is fractured, and then it gives you steps for how to actually fix it or temporize it. So very briefly, very common call scenarios that you'll be encountered during your rotation. I encountered all these multiple times, covers about 80% of what you'll be doing. So really, splinting reductions, lacerations and washouts, and then joint aspirations, most commonly the knee. So splinting and reductions, hip, shoulder, ankle, distal radius, the most common ones. This is another kind of template of what you can be thinking about. For a specific fracture pattern, you can have a specific splint of what to do, and then you can watch a video such as Pocket Pimped online and have a general idea of how these things are put on. And again, AO Surgery Reference is also a good example of what splint is used for each fracture. It gives us, you know, if you're thinking about like, oh, you see a humeral fracture, you're like, oh, coaptation splint, I should be getting these splint supplies. You know, it shows that it's a next level up of thinking. This is a hip reduction. You're gonna most likely at least start out being the person on the right. You're gonna put your hands on the patient's ASIS and you're kind of exerting a downward pressure while the resident starts reducing the hip. So the resident is on this guy's picture to the left. For shoulder reduction, this is might be a common scenario where you're most likely going to be the one on, again, this picture is right, and you provide counter traction, and so the resident on the left is actually reducing the shoulder. Ankle reduction is very common. Your role oftentimes is this guy in this picture. He's doing something called a Quigley maneuver. And you also see the mini C-arm, which you should be wheeling to the room if possible. But you're basically putting your legs, the leg and hip in a 90-degree position, take off tension, and you're holding the patient's big toe, and that naturally reduces the fracture. So this is your job. It's called the Quigley maneuver. And then finally, for distal radius, everyone kind of does this a bit differently. Some people also don't use C-arm for this, but you're going to make a sugar tongue splint. And in this case, if they do something like a finger trap, make sure to try and find that if possible, and then also get the Lido all drawn up. So there's going to be hand bombs that come in the middle of the night where people just, you know, it's going to take 2 hours or so to get everything set up for a lac repair or something of that nature where it's a washout, right? The best thing that you can do is help almost set up a mini O arm for the resident. So I've kind of laid it out step by step. I don't want to belabor the point, but you're drawing up the Lido, you're getting tools, supplies, and by the end, you know, this was also something that a resident is going to find extremely helpful. This is what is going to set you apart. As if you're able to create a checklist in your mind for something like this and then set it up for the resident. And then this is an aspiration for the patient's knee, the most common aspiration. And things to think about is creating an aspiration kit. So getting 10 cc syringes, sterile collection cups, you know, getting the alcohol wipes and getting the chlorhexidine preps, etc. And you know, an ideal student in a perfect scenario, they would have all this set up. By the time the resident got there, they would have prepped the site. They would put blue towels, maybe gotten gloves, right? And then some residents use numbing medication or not. You can get that at least set up, and it shows that you're thinking about it. really you want the resident to come in the room and be like, okay, all I have to do is stick my needle in this guy's knees. Or, you know, you don't want them to getting supplies running around. And I actually set up, or the best students set up kind of aspiration kits. So that's something to consider as well. So the final slide, you know, at the end of the day, you're supposed to be thinking about how to make the residents' lives easier and be a good assistant. And it is, a lot of it is the small stuff, right? You don't want a resident to look bad. You can do small things like getting, you know, resident water. Just know that the resident, oftentimes we don't necessarily need, you know, we're never relying on the med student. And it's, but it's always good when all these small helpful things like, wow, this student was super helpful, they got us water, etc. If it's a quiet night, you don't necessarily need to hover in the resident call room. If we tell you to get some rest, go ahead, get some rest. And it's not a trap. And my personal advice is, it's like I bought Handbook of Fractures. I bought some other like books. I never used them. I think that those 4 resources, AO Surgery Reference, Ortho Bullets, the Pocket Pimped booklet, and of course White Coat Coaching were all instrumental in having accessible rotation. So thanks for your time, and feel free to message or email me at this link below. All right, so that concludes it for me. Thank you.
Thanks, Dan. Next we have Paul, and as Paul is setting up his screen, feel free to send me your questions again. I'm getting a couple of them. We will answer them at the end, panel style. I just threw a couple of the links that were talked about here in the chat, and we will be recording, or we are recording this, and we will be posting it online as well. All right, go ahead, Paul. Thanks.
Awesome. Can everyone hear me okay?
I can, yes.
So hey everyone, thanks for joining us for the webinar tonight. My name is Paul Potna, and I'm current PGY2, so the rookie of the group. I'm here down here at the Medical University of South Carolina in Charleston, and today I'll be talking to you about preparing for Fracture Conference. So the objective of this talk is as follows. We'll discuss the structure of Fracture Conference. We'll learn the basics of how to describe radiographs during Fracture Conference, and build a framework of how to assess and work up a variety of orthopedic scenarios. By this time, many of you have already attended a Fracture Conference in your department, but just to review, the Fracture Conference is typically a weekly meeting attended by all residents and some attendings to review fractures over the last week. For visiting medical students, it's often a time at the beginning of the rotation where you have a chance to stand up in front of the group to introduce yourself, which may include your name, hometown, undergrad, and medical school. And it's often common that a curveball question might come up when you're introducing yourself. For example, at our program, we might ask like what your spirit animal is, but be prepared for that. After introductions, conference will proceed with a resident in front of the group, pulling up a radiograph and describing the presentation of a patient. For example, this is a 50-year-old male, status post-MVC, presenting with the following injury film. Then a senior resident will start asking questions to the junior interns or even a medical student about the case. Now, if you get called on, it may be stressful, but it's a great opportunity to show people you're well-read and prepared. Even if you miss a question, it's an opportunity to learn, as these concepts will come up again and again. There are a variety of resources that we've talked about tonight that you can take advantage of to prepare yourself for the different questions you might face. As mentioned before, Pocket Pimp provides a great overview of many of the questions you would encounter in Fracture Conference. White Coat Coaching provides a number of webinars and modules that talk about a variety of fracture types and their appropriate management. And the Nailed It Ortho podcast also provides podcasts that dig into the details of a variety of injury types. So take advantage of these resources to learn more about orthopedics during your rotations, to demonstrate your preparedness during Fracture Conference. We will now move on to X-ray interpretation, which is the crux of Fracture Conference. As I mentioned before, the case, you'll start with a radiograph that is shown to the group, and someone's going to be asked to interpret the X-ray. So typically you're shown an AP and lateral of the injury and be asked to interpret it, but keep in mind certain injuries may have other special views that may be described, such as a mortise view for an ankle or a sunrise view for a patella. Next, you may also have to keep in mind if the patient's skeletally mature or immature, as this has implications on your management strategy. Especially for pediatric cases, one common question that arises is when certain bones ossify. For example, when describing a supracondylar humerus fracture in a pediatric patient, you may be asked to list the ages of ossification of different parts of the bone, as shown in the table below. After evaluating the skeletal maturity, you're expected to describe the location of the fracture as well. So you should familiarize yourself with the location of the metaphysis and the diaphysis of the bone, but also pay attention if the fracture is in the proximal, middle, or distal 1/3 of the bone. You should also closely look to see if the fracture involves the joint, which differentiates extra-articular fractures from intra-articular fractures. And finally, although it may be obvious, don't forget to mention if the fracture involves a prosthesis, as this itself opens up a different line of questioning. Now, once you get past describing the location of the fracture, there's even more lingo you may have to use to further characterize it. This includes saying if the fracture is comminuted, transverse, oblique, or spiraled. You may also need to highlight if the fracture has any evidence of displacement, shortening, or angulation. And in cases of subluxation or dislocation, you should also know that these will be defined by the location of the distal portion relative to the proximal. So, for example, on the bottom left, you see an AP and axillary view of the right shoulder, demonstrating an anterior shoulder dislocation. And on the bottom right, you see a single view of a knee that demonstrates a lateral knee dislocation. Now, before we put all these things together into the different question types, I wanted to share like a quick tip for you guys. When asked a question, answer specifically to the question. If they ask you to interpret the X-ray, don't interpret it and then immediately begin to classify it. Wait to be prompted, because this gives you a chance to answer a question and then answer more questions correctly after that. So save your knowledge when you can. The next tip kind of goes with the first. Keep your answers nice and succinct. Many a resident you'll see during fracture conference, when they don't know an answer, may become long-winded about their answers and may start off being correct at the beginning of the response, but as they add additional superfluous information, they may say something that's incorrect, and that's something that they might get grilled on. So in summary, just keep your answers answering to the question and keep your answers nice and succinct. So now putting it all together for our X-ray interpretation, this slide just demonstrates a template of how you describe an X-ray. So for the example on the right, there's a series of 2 images of the left wrist. On one view, there's an extra-articular distal radius fracture with posterior angulation and shortening. So this is going to be like your intro level questions, your $100 questions, quote unquote, that you should be able to nail. And then if you get past those $100 questions and interpret the radiograph, you may be able to move on to next level questions. This includes like describing deforming forces on a particular fracture. So this shows an image on the right where you have to describe different muscular attachments to the bone and understand how they might displace the fracture. Other questions on this level will include questions about classifications, which we talked about in a previous presentation. But here's a list of some common ones that you might encounter. And like we said before, Pocket Pip and White Coat Coaching provide some great overviews and specific lessons about high yield ones to know for your rotations. Moving on to the next level of questions, ED management. Sometimes if you get past the other questions, you may have to answer questions about how you might take care of this in the ED. And a lot of this information you'll gain from being on call with a junior resident overnight. But when looking at a fracture film, you may have to request imaging of the joint above and below. So for example, for a tibial shaft fracture, your imaging should include x-rays of the knee and ankle. Also be aware if the fracture is open or closed. For open fractures, your plan should include the patient immediately receiving antibiotics, updating their tetanus, and a bedside washout. Diminished pulses, what you see on evaluation, also has its own algorithm. If the pulses are diminished, the patient should get an ankle brachial index, and if that's also decreased, then they should get a CT angiogram. And then for certain fracture types, the patient may also have to be placed in skeletal traction, either distal femur or proximal tibia, depending on the type. And also be familiar with the types of immobilizations for the different types of injuries. For example, placing a patient in a sling for a proximal humerus or after a shoulder reduction, placing them in a coaptation splint for humeral shafts, short legs for ankle fractures, long legs for tibial shafts, sugar tongs for distal radiuses, knee immobilizers for tibial plateaus or for patella fractures. Finally, no indications for getting advanced imaging. Oftentimes, a CT is necessary as there's concern for any type of intra-articular involvement. Now, at this point, you're truly crushing it. If you get this far, your next level of questions, those $400 questions, give you a chance to further impress the group. So when answering questions about management, the answers are usually either non-operative if it reaches non-operative criteria, or operative. And there are a variety of ways you can fix fractures, which you'll learn the proper way and the appropriate way depending on what level of residency you are. But just being aware, ORAF versus IM nail versus temporary X-fix. And when you decide to suggest a type of fixation for the fracture, have a reason for why you try to choose that. So this again summarizes all the different types of questions. And remember, just answer to the question and be succinct with your responses. So we're just going to quickly apply these things and just do a quick practice case. So this is a 35-year-old male, the status post MVC, presenting with the following injury films. So the first $100 question, what do you see? So this is a series of 2 images of the right femur in a skeletally mature patient. Included are AP and lateral views. And on the AP view and lateral view, there is no oblique fracture involving the middle third of the femoral diaphysis, and there's evidence of shortening and posterior displacement. What is the classification of this fracture type? Although this is not often used, the Winquist and Hansen classification is used to describe femoral shaft fractures, and I would say this is a type 3 due to less than 50% of cortical contact. Now, what are the deforming forces on this fracture? The deforming forces on femoral shaft fractures include flexion of the proximal segment by the iliopsoas, external rotation of the proximal segment by the abductors, and varus angulation of the distal segment by the adductors, and then hyperextension of the distal fragment by the gastrocnemius. Now, your next question, what is your ED management for this fracture? So on presentation, the patient's noted to have an open fracture of the femur. So for ED management, I'll order antibiotics, tetanus, and plan for a bedside washout. I'm going to obtain a good neurovascular exam, and if pulses are diminished, I'll obtain ABIs, and if those are diminished, then I'll obtain a CT angiogram. In terms of additional imaging, if it's not already obtained, I want at least a full length of the femur, an AP of the pelvis, and then radiographs of the knee. And then given the amount of shortening of the fracture after washing it out, I'll plan to put them in traction, most likely with the proximal tibia traction setup. And then in terms of next steps in advanced imaging, then this is dependent on institution. For most institutions, this is enough imaging, but some institutions obtain a preoperative CT scan to evaluate for ipsilateral femoral neck fractures. Now, how would you plan to fix this fracture? As I said before, management strategies for this fracture include non-op, which is rare, but in terms of operative indications, ORAF versus IM nail are both possibilities. And in this case, I'd plan for like antegrade intramedullary nail with a piriformis start point. So that's the end of the case. So hopefully that provides a good overview of the line of questioning you might expect for a variety of fracture types. So thank you all for your attention, and hope this presentation kind of gives you a leg up as you go forward with your rotation. So good luck.
All right. So I will be closing us out, and I will be talking about top 10 do's and don'ts during away rotations. This is going to be somewhat of a different top 10 do's and don'ts. Just to highlight one more time for those people who are just signing on now, we will be posting a copy of this webinar. We will be posting it in our 2 YouTube channels. So I sent the link out in the chat right now. or a little bit earlier. So if you guys subscribe, you should be notified when we post this. So right back to it. This presentation is all about the do's and don'ts while on rotation. So I'm sure most of you have done great on your previous rotations, but these away rotations always add a level of stress. So as I've said earlier, I remember what it was like, how stressful it is to try to make that good impression. And what I was hoping for are specific examples of what sort of things get people interviewed, what sort of things get people blacklisted. And I feel like the gentlemen who proceeded have done a great job of that. So what I will be adding is the mindset version. So what I've come to realize on the other side is that the key isn't necessarily knowing the exact right thing to do, but actually having the right mindset. So I think Jake was the one who mentioned attitude. Students who have the right mindset, and I like to use that word because there's a subtle difference, seem to have a good impression, seem to make good impressions. Only the ones who have the right mindset are the ones who can really see the forest through the trees in these really, really complex situations. When I was a student, it was my dream to be the perfect student in the right place at the right time with the right tool or the right dressing at all times, but that genuinely is not possible. It's rather the students who can maintain the right mindsets. They're not perfect, but they're the ones that we remember. So that's what we're going to talk about, the top 10 do's and don'ts mindset for rotations. To start us off, number one, do get ready to grow. So most of us to this point have excelled at being students, which is basically being able to predict what we're expected to know at what time and then to be ready for it. For the most part, predicting hasn't been that hard because you've been told what you're supposed to know. It's been broken down in textbooks and lecture slides where things are either bolded or highlighted or something, or question banks that we have the answers to and that we can go over and over. Then reminders are sent out to tell us when we're supposed to know it by, and you get the idea. So for many of us, this is the comfort zone that we've developed over many, many years. And I hate to tell you, but all of that is gone now. The real world is super messy. And that messiness is going to feel very, very uncomfortable. So you can tell that we have put a lot of information on these slides, but over and over, you'll have heard this is institution specific. Some institutions will want to do this. Even at a certain institution, one attending will want to do it another way, and one attending will want to do it a different way. And that like messiness can feel very, very uncomfortable when you've been used to having the right answer all the time. Growing requires us to launch ourselves into areas where we will inevitably make mistakes. Being afraid to make those inevitable mistakes can really stress you out, and worse, it can actually keep you from really learning, which leads to the don't. Don't be afraid to make mistakes. Carol Dweck is a Stanford researcher who studied a bunch of kids. She was interested in what was special about kids that eventually went on to be high achievers. The way she decided to study that was she gave 10-year-olds a test that was designed to be too hard. When she studied how they reacted to the challenge, they fell into like two broad categories. For the kids who had a fixed mindset, failing the test was a really negative thing because it basically showed them that they weren't good enough. They believed that success comes from talent. And since they hadn't succeeded, it meant that they weren't talented. And they kind of have a black and white dichotomy of I'm either smart or I'm dumb. For kids who had a growth mindset, on the other hand, it only meant that they didn't know the answers yet. So some of the beliefs that people have in growth mindset are success comes from effort. A failure means that I'm learning and feedback helps me grow. When Carol Dweck asked the fixed mindset kids what they would do next time, some said that they would cheat or hang out with kids who did worse than them so they wouldn't feel as bad. And a lot of her studies showed that kids with fixed mindsets would avoid future challenges just because it doesn't feel good to fail. So as much as we joke about these kids, I can identify with some of their strategies. So I have definitely had moments where I felt better because someone else got the same question wrong, or I have certainly avoided eye contact for a while during fracture conference because I was afraid to get called on. Now, I don't think that this mindset is set in stone. This is probably something that is fluid. So it's not like once you have a growth mindset, you'll always enjoy challenges. I still fluctuate back and forth at times, but it's almost like I have a growth mindset about the growth mindset. So I work to remind myself that when I hit a challenge and I don't nail it, it doesn't mean that I don't belong or that I'll never be capable. It just means that I haven't gotten it yet. This is another way to look at growing that proposes that we have to push past the fear zone before we can get into the growth zone. So in this picture, we start in our comfort zone, and we either choose to move outside of it or we get pushed out of it. For those in this webinar, ready or not, you're about to launch outside your comfort zone. Just outside the comfort zone is the fear zone. And this is where doubt will creep in, and a lot of that discomfort can lead to being super reactive, feeling like the cards are stacked against you. It can also lead to being at the whim of other people's evaluations of you. From here, you've got two options. You either try to retreat back into a false sense of comfort by trying to do only the things that you're good at, or you can continue to go forward and lean into the learning zone. So here you're looking at your mistakes with open eyes, embracing them to figure out how to creatively deal with the cards that you've been dealt. This does not come easy, but you will learn how to expand your comfort zone. Choosing to keep going rather than retreating back to the comfort zone really takes a lot of courage. The next do is easier said than done. So to build self-confidence. Confidence is something that has a lot of downstream effects. So when we talk about mindset, attitude, confidence is one of those things that has a multiplier. When you're feeling confident, you have better access to the stuff that you've already learned. It's easier to be creative and you can connect better with people. When confidence is lacking, a lot of energy is spent second guessing yourself. So how is someone supposed to be confident if they've never done this before? How can you be confident that you're a good ortho student if this is the first time you've ever been at this hospital? You've already missed 2 PIM questions in clinic this morning. Again, mindset is huge here. So while you don't have proof that you're a good ortho student yet, you probably have lots of proof that you're a good learner, that you've been in difficult situations before and have picked things up quickly. Don't waste energy faking confidence about something you don't really know yet, but rather build confidence in the aspects that you do actually know about yourself. You can do this by being really aware of what you focus on. So these 3 statements are basically 3 different ways that you can think about the same scenario. So one that I feel like would grow your self-confidence is thinking about the positive parts of it, right? Like, nice, I just learned 2 new exams today that I didn't know before. In contrast, you could give yourself a really hard time. Like, wow, I missed 2 exams today. I looked like an idiot. I think this is the end. I'm not going to get an interview. Or the sense of false confidence. Any other student would have missed that question too. It wasn't fair. Another do is let curiosity and empathy run wild. So of the mindsets or kind of the attitudes that really get people far is just feed into your curiosity. Why was this technique okay for this fracture, but not the other one? Why do they seem so frantic right now? And that's the empathy part. Like, as people are stressed out, you'll notice that certain things will stress them out more than others. And if you can manage your own stress, you can start to see this more and more. I can point you towards the things that will be helpful. What sort of things make their job easier or harder? We've talked about setting up, noticing abnormal labs, and for scrub tech. So like if you can be really empathetic about scrub tech, it's a really, really hard job. You are responsible for the sterility of the field, and there's constantly people walking in and out, and especially during audition season, every couple weeks, 3 new people walk in, and some of them are better than others, and some of them know how to stay sterile and others don't. So like you could see how that would be really stressful. Hands down, the best advice I ever got was thinking about each patient as your own. So each case you see, each clinic encounter, each consult, imagine that the entire ortho team was suddenly on vacation and it was up to you to figure out what to do next. What information do you need to get from the patient to know what to do? What exam do you need to do to figure out what this is? What labs or x-rays would you need to decide what to do next? And if you don't know, where do you find the answer? So in the messy real world, this is how you deeply learn rather than just going through the motions. Thinking this way is actually how things are going to stick and make sense. Your assignments are no longer going to come in a workbook anymore. It is now like for reals case-based learning. Sometimes you have to look something up while you're waiting for the resident to meet you in the ED. Other times you'll have to get ready for cases later that week. Other times you will have time to go on a deep dive on an interesting patient for like a presentation at the end of your rotation. This is what people mean when they say self-directed learning, that you can pick up on things that you're curious about and really learn about it. So here is another list of resources, and we've talked a lot about these resources. Since this is my wheelhouse, I will highlight the White Coat Coaching Ortho Jumpstart course. So that course was developed as like a very brief overview, like a 10,000 foot view of some things to know before you go. It's like basically a scaffolding on which you can continue to build. So it can seem overwhelming, the amount of information that you need, but the Jumpstart course is actually really useful just to build a foundation that you can then stack more information on. Dan mentioned there are modules and stuff, but I think all in all, it's about 6 hours worth of content that you can definitely do on a weekend before you start your rotations. 5, do know yourself. So knowing yourself is the first step to being able to control your emotions and self-mastery. Only in understanding what drives you, how you do things, what your tendencies are, can you start to step through that fear zone and then towards growth. And this is one of my favorite quotes. Until you make the unconscious conscious, it will direct your life and you will call it fate. Knowing yourself includes knowing the good, the bad, and the ugly. So what is it that you are actually really good at? What are the things that drive you? We all know that we strive to be a certain kind of person, but what kind of person are you when you are stressed? What are your stress tendencies? Do you withdraw? Do you get irritable? Do you get hangry? I know I do. What emotions or situations drain you the most? Only in picking up on these things can you really start to work on them. And then you can really leverage your strengths and also mitigate your weaknesses. One way to do both is to manage your stress. Our bodies basically function in 2 modes, thrive or survive. There will be a lot of stress in the coming months, and if you get overloaded, you will be in survival mode, which for different people might look like fight, flight, or freeze, none of which make you a student that stand out. Sometimes you can't control how much stress you're taking on or getting, and that's when it's really, really important to discharge the amount of stress that you're having. So really understand what your outflow valves are. Is it working out? Is it talking to your partner? Whatever it is, if you don't plan it in, if you don't schedule it in, you are inevitably going to have problems because your stress is going to lead you to self-sabotage. So when we ignore our stress tendencies, we become our own worst enemy. And this is usually what is happening when someone gets blacklisted. Not because they are inherently arrogant or forgetful or defensive people, but because the stress becomes so overwhelming that they slip into a mindset where it becomes unclear what the right thing to do is. The stress can make you someone that's so tunnel vision that you lose track of your surroundings and tell that inappropriate joke. It can make you less able to read the room. This is something that I will post in the chat as well. I found it really interesting because it helps you identify like what are your most likely ways of self-sabotage. So as an example, say you're doing an ER consult as a student, your resident is working on the last consult, and you probably have about 30 minutes before they come. So one of my self-saboteurs, or the ways that I tend to get in my own way, is I can be a stickler. When I get stressed, I feel like I need all the right answers. And if I only have 30 minutes and I'm in this like survival mode, it can be hard for me to see all of the big picture of like what is most important. It can be hard for me to prioritize things. And so what that could lead to is like going from number 1 on my list and only going to number 2 after I finish number 1 and number 3. And that could mean that I'm only on step 2 when the most important one was step 5. In contrast, if I was in thrive mode and I was able to see the forest through the trees, I would be able to tell what sort of things are most important and try to focus on those and get as much done as possible. Number 8, the last of these are more practical. Do ask for feedback. Specifically, I think it is important to ask for feedback several times throughout a rotation. I recommend doing it once in the middle of your rotation and once at the end of your rotation. Like Dan said, the OR days are very high stress for a lot of people. So during clinic or like a slower call day, or some places will have morning report before everybody goes off for their daily assignment, that might be a good time to ask. You can ask attendings, you can ask residents, and it can be as simple as, hey, I'm at the midway point of my rotation today. Do you have a second now or later to give me some feedback on how I'm doing? Feedback is gold, especially good feedback. If someone actually tells you something that you can change or do something with, like that is gold. And that's actually why I recommend doing the midpoint one, because if you've asked someone for feedback at the midpoint, then you have a chance to make a change. And then if you ask that same person at the end of the rotation, you can talk about like what you did with the advice or feedback that they gave you. Last, don't be late. I think we've talked about a couple times that it's not hard to have someone have a knock on you. And there are many that are forgivable things like not knowing the answer to a question, not getting a $400 question. But I feel like something that does stick is if you're late. So do everything you need to know, everything you need to do to get to those places on time. And lastly, but definitely not least, is to have fun. It sounds crazy after we've just stressed you guys out with all of this stuff, but this is a large chunk of our lives. 4th year medical school. Remember to have fun and enjoy the journey. Have beers with the residents, and I put probably not shots because remember, you want to respect them, and you're not best friends yet, but definitely enjoy your time. It's a small world out there. You will probably work with these people down the road, if not the other residents, your other students. And if you can, spend some time to see where the residency is located. This is 5 years of your life, and it'd be nice to know kind of the area that you're into. All right. That's what I have for you guys. I am going to answer a couple of these questions. All right, so here's a good time for everyone to ask as many questions as you have in the chat. I actually have kind of a specific question that I'll pose to everybody and see what everyone thinks. So someone said, I am starting a rotation on 9/11 at a program that a letter from would go a very long way. With ERAS being due 9/27, do you think it's possible to get a letter in time? Can a letter be obtained later than 9/27? Does anyone want to take that?
Here, I can weigh in. I think with 2 weeks left before applying, there might be a risk with getting a recommendation from there. But at the same time, attendings have to write these letters of recommendation last minute all the time. I think my advice to you would be since you can have more letters of recommendation ready before you apply, like more than you need, I would just have all the recommendations you need going into that rotation. And then if you have a great rotation and you want to request a letter of recommendation from one of those attendings, they feel comfortable with the time constraint, then you have that letter that you can obtain before applying. But if they say, no, I don't have enough time to do it, or you have a bad rotation there, then you don't feel pressured that you're missing a letter, and you still have the ones from before.
I totally agree. It's like mitigating it. It's not impossible, but you don't want to stress yourself out by relying on that letter. Another question. Are there any resources or videos that you recommend to understand varus valgus when interpreting x-rays? So yes, you guys are all going to feel a lot of stress around interpreting x-rays. Pocket Pimped Instagram, follow that. They have a lot of really great videos on how to read x-rays. There are some with the White Coat Coaching Instagram as well. And I would actually recommend, if you go to the White Coat Coaching YouTube channel, there is one video about fracture fixation that I think goes over varus and valgus, and maybe not so much about x-ray reading, but it does mention it there. All right. Well, thank you everybody for participating. We will again post the video or the recording of this webinar. We'll post it actually both on the White Coat Coaching and the Pocket Pimped YouTube channels, and that should be available hopefully next week as we do this. All right, thanks everybody.